Okay, we are now broadcasting. Great. And we have 9 attendees coming in. Okay, guys, great to see everybody jumping in. Perfect. I'm going to just slowly start talking as more attendees join into the chat. And let me say welcome, everybody, for joining us. Thank you for you guys for joining us online from wherever you are in the country or world. And this is our, I think it's our 4th annual, right, Ron, online residency chat. I briefly just wanted to say my name is Errol Zdalga. I'm one of the hospitalists here. I oversee communications, which is why I'm kicking off this chat, and also the Stanford 25. Probably most importantly, though, I was a resident here when Dr. Witteles took over the residency program. And as this chat is an opportunity to learn about our residency program, let me just say, as I often say when I have interviews with many of you, what a privilege it has been to be a resident here and train here and see how this program has grown so much. And so our goal is to share with you some of the things that we love about this program and answer any questions you have. So with that, I'd like to turn it over to our MC and our program director, Dr. Witteles.
Thanks, Errol, and thanks everybody who is joining us. This is, as Errol was saying, I think the 4th time we've been doing this. It's a nice way of capping off the interview season for all of us, and is really a lot of fun. This is such a fun few months for us. I hope everybody who went around the country interviewing enjoyed it as well. As Errol said, the point here is really to answer questions. We realize that for some people, it's been a while since you were here a few months ago, and programs start tending to run together. And we want to make sure that you have all your questions answered so that you can make the decisions that are right for you. So we have a great panel of participants here today to answer questions that people have. Before I turn it over for introductions, I will say that please start submitting questions. You can write the questions. And actually, Errol, do you want to let them know how to do that?
Yeah, so there should be a question module where you can click on it and simply just type in your questions. I think almost all of you have logged in with your name, so let us know who you are if you're comfortable with that. And please ask any questions you'd like. Our goal here is to help you understand our program.
Pseudonyms are fine too, for the record, but just start typing in questions because that is going to be the main goal for the hour. Right now, let's start with introductions. My name is Ronald Witteles. I'm the program director. It's surprisingly, incredibly enough to me, this is the 11th year I'm doing this, and it's really a lot of fun. This really never gets old. And thanks again, everybody, for interviewing with us and for joining us. Let me turn the floor over to Angela Rogers.
Hi, everyone. I'm Angela Rogers. I'm one of the associate program directors. I think, in my 5th year as an associate program director. I am an intensive care unit physician, and I'll give the caveat that I am on service this week. So if I disappear, that's why, and I will try to come back and answer any questions related to ICU you might have. So in addition to working in our intensive care, because of that, I'm very involved with our med anesthesia program, and also work a lot with our residents on research in residency. If you have questions about that, I'm also a physician scientist here at Stanford, as you know. So excited that you're calling in to learn more about our program.
Becca, do you want to take it?
Sure. I'm Becca Tisdale. I'm one of the current chief residents, so hopefully met all of you, or at least the great majority of you, on your interview day here. So happy to answer questions about being a resident, which I was quite recently, or anything that falls under more of the chief purview. And if we talked about this on the interview day, let me remind you, I was also in the global health track, and I am going into health services research fellowship next year, and then cardiology. So happy to speak to any of that.
Great. Maybe Adrian?
Hi, everyone. My name is Adrian Castillo. I am one of the current PGY3s. I am going to be one of the chief residents here next year. And after that, I'm planning to go into cardiology. I am obviously happy to answer questions about my experience as a resident and why I was excited to stick around to be a chief. I will now go ahead and pass it on to Elena.
Hi, everybody. I'm a PGY1 right now, categorical internal medicine resident. So I'm happy to answer and field any questions related to intern year that you might have, hours-wise, work-wise. I'm also planning to go into cardiology and also happy to talk about research, doing research as an intern, and anything related to health disparities that you might have is a particular interest to me, and happy to talk about like working with patients here at Stanford. Happy to be on here.
Thanks, Elena. And I'll point out this is Elena's day off. So a special thanks to Elena for joining us. Dr. Harrington.
You're welcome.
Yeah, hi. Apologies for being a moment or two late. Errol reminded me that I needed to log in as a participant, not as a student who's applying. So my name is Bob Harrington. I have the privilege of being the chair of medicine here. Like many of my colleagues, with the exception of Errol and Angela, I'm actually a cardiologist as well. And so we can answer a lot of questions about, I would say, the bigger issues of what we're trying to accomplish at Stanford Medicine within the department, the many, many opportunities for both clinical training and research and education opportunities. So glad you're joining us and happy to participate.
Great, thank you. So thanks. We already have some questions coming in, and please keep them coming. So again, anybody who just joined us, please click on the, I think it's the chat portion, Errol, is that right?
Yeah, there'll be a question and answer, Q&A button you can press.
And just type questions in the goal during the hours. We are going to answer all of them, or at least all that we can in the time that we have. So please go ahead and ask. Why don't I go ahead and do the first, which is how diverse is the patient population? And maybe we can talk to our two current residents about that.
Yeah, I'm happy to start, and Adrian, you can jump in. I know starting as an intern here, I had come from a kind of a 3 hospital institution. And so, I was a little bit curious about how this was going to work at Stanford with the Stanford Hospital and then with the Palo Alto VA. And I really wanted to make sure I had kind of a county experience. And I can really speak to the fact that I have had an incredible amount of diversity of patients. I have used a ton of different interpreters. I have seen patients from every different insurance, without insurance. I've been absolutely so thrilled to take care of patients at Stanford and feel like I'm really treating like the whole community in Palo Alto. And I genuinely mean that. So I just really enjoyed the diversity of patients here and feel like I walk from room to room. And I know Errol was my attending, and we shared quite a diverse group of patients, and it's just such a privilege. So I don't know, Adrian, if you have anything to add to that, but it's been one of the most special things about being at Stanford.
Yeah.
And by the way, you did a great job, Elena.
Oh, thank you.
Yeah, and I would absolutely completely agree. I know when it came for me looking at programs, having both multiple sites to train at and the ability to work with a very diverse patient population was incredibly important to me. And this has absolutely fulfilled that. I mean, I think if you look at just the VA population, that was a group that I wasn't that familiar with from my time in medical school. But it's a population that has its own kind of unique challenges and struggles. Obviously a lot of issues with mental health and substance use. A lot of these veterans have very little social support. And so getting to learn more about that population and being a part of that's been wonderful. And even Stanford itself, obviously I think some of the nearby areas around here are, quite wealthy, but our catchment area is really large and gigantic. And we have people coming from all throughout Central California and a lot of the rural parts of the state, because this is the nearest hospital to them. So you really do draw from a very diverse part of California and see people from all different walks of life. So I think it's been a really robust experience here.
Thank you. Click here. Okay, so next question is wanted to hear more about the residents' involvement in free clinics. So I'll say a couple of words about this, and then again, maybe either of our residents or chief resident can speak to this. So we've really been proud that for many years we have our free clinics that are really co-run between the medical student undergraduate side, but also with our residents. That traditionally in most places around the country, the free clinics are very much the purview of medical students and not the residents. And we really view that as a lost opportunity for all involved. That it's a great opportunity for residents to get to work with medical students in a different setting with more autonomy, with the ability to spend time teaching, and we hope really are able to add a lot to the patient care for the patients who are being seen in the clinics. So we have a couple of our residents each year who are elected to be the free clinic representatives who work with the students and the free clinic leadership team to run the clinics. Maybe I can turn it over. Becca, I know you also, this is slightly different from the free clinics, maybe you could speak to as well, because you had your continuity clinic at our county clinic for San Mateo County. Maybe you could speak to that a little bit to the free clinic experience.
Yeah, absolutely. So exactly as Dr. Witteles said about the free clinic, so all of our residents participate. In the second and third year, everyone does at least 4 free clinic shifts per year. So it's definitely very built into our program, and you can do more if you want to. And like Dr. Witteles said, you can take a leadership role in coordinating the clinics as well. And with respect to the time we actually spend in free clinic, like he said, it's meant to be a chance for the residents to practice the attending role, really, that there is an actual attending there if you need them. But the idea is that the medical students kind of go in and do the initial patient history and physical, and then you get to kind of coach them through that patient encounter and go back in with them and teach at the bedside. So that is a very valuable experience. And then with respect to Fair Oaks, which is the county clinic that Dr. Witteles mentioned, which is where I had my continuity clinic throughout residency, as did my 2 co-chiefs. It actually relates to the prior question as well, because it is a safety net clinic serving a very diverse and underserved vulnerable population. And Elena, you're there too, right? So yeah, I can't say enough good things about it. I think the mentorship there, both clinically and life-wise, is wonderful, and the patients are a delight. And my Spanish got so much better over my time in residency because of Fair Oaks. So happy to email and talk more about that if people are interested.
Elena or Adrian, anything to add, or should we go on?
No, I completely agree with everything Becca said.
Okay. That typically happens, yeah. All right. Okay, maybe I can turn to Dr. Harrington for this, for an overview, and I can give some thoughts, and anyone else can chime in as well. So could you briefly discuss the new hospital and how it has affected patient care and program mechanics?
Do we have an hour or so to talk about? So for those of you who visited us after the new hospital opened, which I think it's many of you, you know that it's a beautiful facility that took 7 years to build. And it's offering, I think, a lot more space, a lot more opportunity, a lot more access to high technology, all of which is good. The challenge has been, frankly, trying to figure out how it all fits together with our current facility. So it's very much a work in progress right now, but I think opening it tells us that there is opportunity to continue to grow different programs. What we've got to figure out, I think, is how we grow those programs in concert with everything that all the departments are trying to do. As part of that, we're also in the midst of building a new multi-specialty office building up at our Redwood City campus about 4 miles away. And so I think you'd find coming to campus now, there's an enormous amount of excitement around growth and doing things differently, but we have a lot to work out before I would call it efficient and streamlined.
I'll give a couple thoughts, and then again, it'd be great to get anyone else's on the panel. So I'm on service right now, actually. I'm a cardiologist. I attend in the CCU heart failure service. So this is because of interview season in the last couple months, I couldn't attend. So Saturday was actually the first day I've been on service since the new hospital opened in mid to late November. Cardiology is almost entirely in the new hospital, what we call 500P, because the address 500 Pasteur Drive. So my reflections on it from this week, at least, number one, the facilities really are amazing and were built very much from a patient experience in mind, down to the artwork everywhere. But I'd say the things that strike me the most are it's quiet. You know, hospitals, particularly academic hospitals, and certainly how it used to be here. I mean, you'd walk in the hallways and it was loud, and it's tough for patients to get sleep. It makes it just a less pleasant experience, certainly to be a patient there. Now you walk around and it's quiet. It's a much calmer feeling. Number two is that the patient rooms aren't just beautiful, and they have some of the best rooms, I think, best views in Palo Alto with these floor-to-ceiling windows, but it humanizes the dehumanizing experience of being in the hospital in a very real way, where as much as it can be, I think you have lots of room for family and friends to visit. Again, you are in a place with big windows, lots of natural light. It is clearly a much more pleasant experience to be a patient there, and I think makes it also more pleasant to be a provider there. I think in terms of the challenges, probably the biggest one is early on has been co-localization, which has been for some services relatively straightforward, like the cardiology service is almost entirely in the new hospital 500P. For the wards, we've been much more split, and we're actually actively exploring ways to address that, and I expect in the coming weeks we're going to make some adjustments to address. Let me turn it over to anyone else on the panel.
Ron, I've been on service more days than not since the new hospital opened. I'm on service. I just came from rounds right now, and I'm in a hospital medicine. It has been some growing pains as we expected because it's a new hospital. But we are working on making a lot of changes. And one of the nice things is throughout this year, and maybe the residents can speak to this as well, but there's a lot of changes coming in mind. There's new services opening up. Oncology is expanding. We're actually going to have not be as busy. And so one of the things I always like to share when I meet with residents is one of the cool things about this program is every single program, there's issues that come up. What I love about this program, and it's been the case since I was a resident, is you have a huge voice. And when things come up, the changes come from it. So one of those changes right now are adapting to a new hospital. And one of the things that we are doing is growing and responding to that, because the program is always looking at ways to make sure the resident experience is one that you are not only working hard and learning, but also able to breathe and grow in many other ways.
Any other thoughts? Shall we move on? We'll move on. Or sorry, Elena, were you saying?
Yeah, I was just going to say that just speaking to like kind of being on the ground as the intern kind of running from different patients' rooms, it's been a little bit challenging with getting, from one side of the hospital to the other if you're concerned about someone that might be sick or, something like that. But I think that it actually has been really amazing to see, and we were all a little worried as interns about being able to manage this new hospital, this new change. I'm like, I don't even know where things are in the old hospital. How am I going to know where things are in the new hospital? But it's actually been really incredible just to see like my chiefs especially like be so engaged with us. And it's interesting to get to see kind of how you get this huge challenge, like how is your program going to respond to it? And are they going to listen to your concerns? And it's been really incredible to see how, there are growing pains, like Errol mentioned. I think we're tweaking different things, but it feels like at least we have some agency over making changes that are going to help us to be able to better take care of patients. And that's just really great. And so once you see patients healing a lot better in this new hospital, and you're able to kind of take care of them and manage the co-localization, it's just been, I think it totally overall is moving in the right direction. So it's been really reassuring.
Right. Thank you.
Thank you, Elena.
Yes, both for the answer and for the shout out for your chief resident. All right. Is the salary manageable with the cost of living in Palo Alto? I will certainly turn that one over to our residents, and Becca, you can certainly chime in as well.
Yeah, I can say, at least from my experience here, the compensation we receive here is certainly enough to live comfortably in Palo Alto or any of the nearby cities that most of the residents live in. I think, obviously this area is very expensive, but you know, there's a lot of expensive areas in the country, and I think relative to, you know, some other areas, I think we're actually quite well compensated. And I know for me, I actually found it relatively more affordable to come here because of between the housing stipend and our salary, we make, you know, enough that more than compensates for the increased cost of living here. So I'm able to live comfortably in a nice place. Me and my wife go out to dinner, go on vacation. I'm paying off my student loans and still saving some money. So you definitely make enough here to live your life and enjoy it, you know, when you're off.
I'll say that when I was moving to Stanford, I was told get a small house and a good bicycle, which I think is really good advice, because the truth is that there is a lot that you can do here that is free. You know, there are unbelievable redwood forests and the beach that are a half-hour drive away, and then you can hike on the weekends. And I'll say that my impression of the residents too is that the salary is quite high, and there's not a lot of moonlighting. You know, like that people are given enough that they can live instead of moonlighting. And so what you see is that the residents that are on elective are doing their elective and then spending time with their family rather than trying to make up more salary. I think Stanford's model is actually much, much better.
Yeah, I always think that the main thing that is a financial challenge for most residents would be buying a home. In terms of rent, it's really not that different from a lot of other places. I mean, I was coming from New York, so that's another expensive area, but I was able to pay about the same and get a lot more for my money here rent-wise. And I also got a good bicycle, like Dr. Rogers recommended. And a lot of the activities that are fun around here, like she mentioned, are really low cost or free. So that helps too.
Great, thank you. All right, can you speak more about the structure of subspecialty rotations and the resident roles? Are those rotations all inpatient or all outpatient, or is it a mix? So maybe I'll give an overview of that, and then again, anybody please jump in. So first off, in terms of the inpatient rotation, so it depends on the hospital. So at Stanford Hospital, we have a Stanford wards rotation that is mainly, most of the attendings are the hospitalists. There are chief residents attend and a small number of the subspecialty attendings, but it's mainly at the academic hospitalist group, of which we have a tremendous one that Daryl's a member of. We have, in terms of other specialty inpatient rotations, there's 2 in cardiology, the one that I attend on, which is the CCU heart failure rotation, which is a combination of the CCU and inpatient heart failure. There's a general cardiology rotation, which is pretty much everything else in cardiology, I mean, ischemic heart disease, arrhythmias, et cetera. Then we have a inpatient hematology rotation, which is predominantly in patients with acute leukemia, but some other hematologic diagnoses as well. And we have an oncology rotation, which is predominantly individuals with cancer who have complications that cause them to need to be hospitalized. There's other opportunities for sort of subspecialty rotations, like a bone marrow transplant rotation, but that's an elective. The others are all core rotations. Now, at the Palo Alto VA and at Santa Clara Valley, they are much more a general wards rotation. And so if you're at the Palo Alto VA and you have the patient coming in with acute coronary syndrome, for example, they'll come to the regular medicine wards team that, again, is staffed almost exclusively by the academic hospitalist group, and then obviously with the subspecialty consultants as needed. There's ICU rotations that Angela can maybe speak to in a moment, that we have at Stanford VA and at Santa Clara Valley as a elective as well. In terms of the inpatient-outpatient split, actually one of my first goals when I first became program director over 10 years ago was to try to move more of the particularly subspecialty training experience from the inpatient to the ambulatory arena, as we know how much of medicine is practiced in the ambulatory arena, and internal medicine residency has traditionally been very inpatient focused. So our program is structured such that intern year is pretty inpatient focused. You are doing, as Elena can probably nod to, so yeah, you're doing a lot of the inpatient. I mean, part of that is because we want to make sure that when you're starting and running a wards team, which could be the first month of your second year, that you feel confident to have the experience to do so. But residency, of course, is a 3-year experience. So of course, there is ambulatory time besides your continuity clinic, but for subspecialty ambulatory time as well as an intern year. But really it's second and then even more so third year where you have those opportunities. And the way we view it is that if you're on, for example, your GI consult or nephrology consult rotation, we don't want you to just be caring for inpatients with GI bleeds or on dialysis. Those are important patients with important problems, but the majority of those fields, the richness of the fields, is really in the ambulatory setting. And so for most of our subspecialty consult rotations, we split it down the middle. So you'll spend 2 weeks inpatient, 2 weeks outpatient, not one of these things where if there's time, maybe you stop by the clinic, but where where for those couple of weeks, you're expected to be there. And we try to have a thoughtfully designed experience. So you might spend on your GI clinic a day in esophageal disorders clinic and a day in IBD clinic and a day in pancreas clinic and so on and so forth. But really trying to emphasize the ambulatory side of medicine, not only in general medicine, which of course you'll have your continuity clinic and a host of opportunities for electives, what we call enrichment rotations, but also across all the core subspecialties. Let me stop. Maybe Angela, do you want to speak a little bit to the ICU experience, then we can turn to the rest of the panel for any thoughts to that question?
Sure. I think a great thing about our residency is that, you know, especially in your second and third year, you can organize a lot of what you, organize your schedule the way that you want to. So if your passion is critical care, ABIM says you can only do 6 months, but that means that's actually a lot of critical care you can do. Everyone rotates through the CCU, through the VA ICU, and through Stanford ICU. If you're interested, and most people do what's called an ICU triage block as well, where they're in charge of sort of deciding which of the floor and ED patients come to the ICU. If it's your passion, you can also do some time in the cardiovascular ICU where you learn about ECMO. You can do an elective at Santa Clara Valley ICU, which is super popular in part because, you know, it's a little bit less tertiary. So while our patients are super sick and will prepare you well for a critical care career if you want, at the Valley, you'll have a little bit more of a bread and butter ICU experience, which is also really great. So we train our residents spectacularly well in critical care if that's your interest. Contrary to the panel makeup, not everyone here goes into cardiology. So we're ready for you.
The rest of our panel, any thoughts? Not, I can move on. Okay. Question about telling how outpatient primary clinic is organized. So we have 6 different sites. I'd say 3 main sites and then 3 smaller sites. So our 3 main sites are Stanford Internal Medicine Clinic, which is just as you would imagine. It's a internal medicine clinic based at the main Stanford University Hospital. We have VA Clinic, which years ago is where I had my continuity clinic. A wonderful spot, particularly for people who are interested in caring for patients with chronic cardiovascular, chronic lung disease. And then the Fair Oaks Clinic, which Becca was speaking to before, which is a county clinic. It is always exceedingly highly rated, really well-run clinic with a great patient population to work with. And I guess, Elena, I think you have your clinic there as well. We have 3 sites that are smaller but provide really great opportunities for residents who have interests in different models of primary care, which are community-based sites run out of Stanford at Los Altos, at Portola Valley, and Santa Clara. Dr. Harrington, maybe do you want to just talk about Stanford healthcare in the bigger picture to that end, and then maybe we can get any other thoughts from the panel?
Yeah, thanks, Ron. So for most of our history, Stanford had really been academic tertiary quaternary medical center here on campus. And over the last 7 or 8 years, we've really built to be a large regionally oriented academic health system. We have a large network that is totally affiliated with Stanford of several hundred, mostly primary care doctors in the area, but not exclusively, and mostly in the East Bay and South Bay. And I think what that gives for the training opportunities is that increasingly we have the option of, particularly in the elective services, of having our residents, our fellows, train more in the community if that's what they choose to do for some of the rotations. We have a hospital now in the East Bay that has increasing presence of both students and residents across multiple disciplines. We have large ambulatory facilities in the East Bay and the South Bay, and again, same sort of training opportunities. So yeah, again, it's if you're looking for a county experience, we have it, a university experience, a VA experience, and now we have a variety of community-based experiences so that you can so that you can really round out your training. And I think that that is a real strength of the program, that you get the breadth of all of those opportunities.
And I would just add, I imagine where that question may have been hinting at too is how do you balance, going to your clinic in the afternoon when you're on like an inpatient service and having to juggle both of those. And I've actually found that I think it's something that's quite doable and ends up really not being kind of much of an issue for people here. On those days when people have clinic and you're on the inpatient service, for instance, we all know that and understand that, and we'll kind of run our rounds in a way that helps to accommodate that. So for the intern that has to go to clinic, we'll try and see your patients first and allow you to go and get your work done, or as much of it as you can get done, before going off to clinic. And I know for me, like as a resident, if we have a really busy service and the intern can't, finish all the notes, like I'm happy to finish that work and, make sure you can get off to clinic and focus on taking care of your outpatients. The one nice benefit, I think, having our clinic structure the way it is, where we just kind of have half days of clinic scattered, periodically on an ongoing basis throughout the year, is that it gives you more short-term follow-up with your patients. So, for example, right now I'm outpatient, so I have clinics kind of every week. And I saw a patient last week who had kind of a mild heart failure exacerbation that I felt I could treat safely as an outpatient. And it's nice that I can see him again next week in clinic to kind of follow up, see how he's doing. And that kind of short-term follow-up is really nice because you can take a lot of control over more kind of subacute outpatient issues, rather than have like when your colleagues in your same firm see them next week or the week after, because you're not going to be back for another 4 or 5 weeks in clinic. So I've really appreciated that.
Great, thanks. Yeah, I'll say for clarity's sake, in terms of how our clinics are set up, we don't have that X plus Y system that is that some places have, and that's intentional. We've discussed it many times over the years that, like most things in life, there's pluses and minuses. The minuses that are the reason why we haven't done it is that it really fixes the schedule into a pattern that allows much less flexibility. So if a resident, for example, wants to do a global health rotation overseas for 6 weeks, or when it comes fellowship interview season time and they need to be on rotations that they can more easily miss to go on interviews, we have a lot more flexibility to work with the residents to schedule if they're not locked into, for example, 4 weeks inpatient, 2 weeks outpatient, every 6 weeks, just like that. However, we do certainly, as Adrian was just getting at, concentrate the clinic experience on the less busy months. And so when you're on an inpatient month, and particularly if you're on an ICU month, for example, you're going to have, depending on which type of rotation, 1 or 2 clinics, and that's it. Whereas if you're on a ambulatory or outpatient, an ambulatory or consult rotation, you'll have 1 to 2 clinics per week. And so we try to find a balance in the middle, and overall, we found that this is what works best for our residents. All right. What mechanisms are in place for residents to provide feedback? How does the program go about analyzing and responding to feedback? So I'm glad, thank you for asking this question. A couple of things I want to highlight, and then again, I'd love to turn the floor over to our panel. So we have a couple of different mechanisms. So one, of course, at the end of every rotation, our residents will fill out an online evaluation that is both of faculty, the faculty they worked with, and of the rotation itself. We take that data and use it in a couple ways. We actually have a once a year meeting where we sit down with class representatives and actually also go over every single rotation that works with residents in the program to get additional feedback. And we give that along with the objective data that's entered electronically to the division chiefs for feedback for the faculty. And I should say that that is blinded, so the faculty faculty can't see who writes what. So people, not that there should be any fear of being honest, but given the sort of the power disparity, that takes it away completely. We then have a meeting at the end of the year called the annual program evaluation, where we review the data on each and every rotation from our electronic system. And we actually publicly show for all of our residents the rotation rankings, 1 to 60, or however many there are. It's about 60 different rotations. And we can specifically focus on the ones that aren't ranking as well, why not? And often we might discover something like, oh, the rotation director changed, or such and such experience changed. And it allows us to be able to quickly identify and address it. Now, for changes in the program in general, we have what's called the Committee on Residency Reform. And this is a once-a-month meeting. It happens the first Tuesday every month, like clockwork. It's not a meeting we say is monthly, but it's really quarterly. It is every month. And we come in with an agenda. Anybody can submit an item to the chief residents in advance to add to the agenda. And there's elected class representatives, but all residents are not only allowed, but encouraged to come and participate. And this is really the mechanism we have to try to quickly turn resident feedback into action. And that's what the goal of the meeting is not just talk a lot and nothing ever happens, but be able to get the feedback and quickly turn it into action. Sometimes we're able to vote and make changes right then and there. Sometimes we need to take that feedback, circle back with others, and then come back the next month with action. But that is the main mechanism. It really tries to have the program be very responsive to those on the ground. Let me turn it over to others.
I would add that in addition to these electronic forms and CRR, the committee that meets every month, we also have created a culture of giving verbal feedback, and that's very important. So at the end of every rotation, every time your attending goes off service or you go off service, the expectation is that everyone will meet up and swap feedback. So it's really an expectation so that it's not something that only happens if you're doing less well or extraordinarily well. It's just something that should happen all the time. And in my experience, I have seen that happen very consistently, and that's really helpful.
I would also say that Stanford is just a very unhierarchical place. And so we try really hard to have it be that every resident has different people. You know, sometimes it'll be an associate program director. Every person that comes is assigned one of us, and we go to dinner together multiple times during the year. Each of you will have a chief that you'll meet with that, to check in occasionally. You'll often have a research mentor who's a person that you like, or, awards attending. And that means that when you're having a hard time, if there's something you feel like is going badly for you, there's usually someone in your life that you feel comfortable talking to who's involved with the program or who's in leadership at Stanford. And that's really helpful when times are hard. Thanks.
Angela, I've got to say, I'm seeing your whiteboard in the background, and that is the greatest example I've ever seen of the diversity of research that occurs at Stanford. That's well done. You want to say something so people can look at that whiteboard?
Oh, there are a lot of empty boxes for papers that need to get out of the door, but one of them is Andrew Morris, which is just waiting till I go off service, and we're going to send it in. So thank you for noticing. I erased my child's strange cupcake that was at the bottom right before this meeting.
Very nice. I think there are a couple of questions on research we'll get to in a moment, but I thought this one, Errol hasn't had a chance to answer much, and this would be right up his alley. How much training on point of care ultrasound is integrated into the curriculum?
That's a good question. So in many different ways, we try to integrate that, and it's also something that we are continually working on growing. We have a couple of faculty members like John Kugler, Anjay Kumar, Charles Lau, who run, particularly John, a dedicated ultrasound course that residents can do throughout the year and become very good at. One of the things we're actually working on right now, our whole BedMed group actually, we're ordering like 10 butterfly ultrasounds this week. And we're working on getting more devices for the interns, residents. We're working on a grant right now to get more devices just for all the residents, because one of the issues, you have to have ultrasounds everywhere to learn. So we have a program. We're working on getting more devices. Part of the Stanford 25 sessions that we do ultrasound teaching. We encourage all the ward attendings and other attendings to have ultrasound and teach it on the bedside. as Ron and all the cardiologists know here, you can learn a ton. Our cardiologists here are great at looking at official echoes, but a lot of them are amazing at bedside ultrasound as well. We always go and look at echoes with the cardiologist for a more high-level take. But for point-of-care ultrasound, and we were just meeting yesterday, we're working on a new ultrasound series for the Stanford 25, which is dedicated to ultrasound. Ultrasound is by far a big part of the future. Obviously, it's not replacing all the stuff that we do, but it empowers our bedside exam tremendously. And we're really excited about how excited incoming students and residents are for it. So we want to take advantage of that.
Adrian, as someone finishing the program pretty soon, how much opportunity have you had to use ultrasound across your various rotations?
Oh yeah, it's been great here. And I think it was something that was important to me as well as an intern. And one of the great things I found is, in addition to some of the more kind of formal didactics, a lot of the residents here are really interested in point of care ultrasound. And we're really excited to teach me as an intern. You know, I remember one of my first blocks on nights, one of my first or second months as an intern, I just asked one of the seniors to, you know, if he wouldn't mind showing me on one of the admissions we had, you know, how to do like a bedside echo. And starting with there, I was able to just kind of learn. In the old hospital, we used to have, you know, pretty good access between all the ultrasounds in the ED, and then there were, you know, kind of smaller little portable ones on the unit. But one of the great things I found so far is every unit I've been to in the new hospital, I think has ultrasounds like as part of the unit. So like really nice, the actual big ones you can wheel to the bedside and get really good images with. And so I know for patients in the new hospital, it's been very easy to just go grab an ultrasound to do quick assessments.
Thanks. I'll say, as you know, as an attending in the CCU, it's amazing in the last few years with how much more ubiquitous the ultrasound is available and how much training the residents get now, that I will routinely, when a resident's admitting somebody on call and they have a question about something, they will send me just in real time at home the images of the echo that they're getting, and they get with their point of care machines, and they get impressive images, and it's really tremendously helpful because you don't necessarily need to be trained to identify a subtle wall motion abnormality, but being able to identify the major things is the ejection fraction 20% or 60% is their big pericardial effusion, et cetera, I would say people become tremendously comfortable with. Okay, as promised, there's actually a lot of questions about research, so rather than clicking through each one, we can talk about it in general. Here's one of them asking about what opportunities are there to do research. Maybe I'll give a brief overview, and then maybe our current residents and recent graduate can speak to their experiences. So Stanford is a research-intensive institution, and we wear that very proudly. It's been a big part of our history. It's very, we see it very much as one of the three pillars of the tripartite mission of academic medicine, and something that Stanford has done very, very well for years. Now, residency, of course, is and should be predominantly about learning the skills to be able to care for human beings with internal medicine problems across this very wide spectrum. However, part of the advantage of training at a place like Stanford is being able to spend that extra time to work with faculty and get meaningful scholarship done. So we put a big emphasis on this, and a lot of this is by trying to get people linked in very early on with research mentors, so that even if as an intern you're not necessarily doing lots of research, and some of our interns have been amazingly prolific even during intern year, but even if as an intern all you're doing from that standpoint is getting to know a mentor, planning a project, getting an IRB ready so that you can really jump into it in second year, it really matters that you can get something done because residency, the time will fly. And if you're, for example, applying for fellowship, you're doing it at the start of your third year. And hopefully it's nice to be able to have something substantive to point to that you accomplished over that time. So our residents are really tremendously productive. We have a resident-run research newsletter that actually one of our chief residents next year, not Adrian, but one of his colleagues, Andrew Moore, whose research mentor is Angela Rogers. He co-runs a resident research newsletter that comes out every quarter highlighting the work that our residents do. We have an annual resident research symposium each spring, and this has been exceptionally impressive, where we've had over 50 residents each year presenting the work that they've done in the last year. And this isn't case reports, it's original scholarship that they did with a faculty mentor here, and it's really impressive stuff. So let me turn the floor over, though, to those who are actually living it. So maybe Adrian, Becca, and Elena.
Sorry, I had to unmute myself. Yeah, so, you know, as an intern, it's difficult to be able to get the time to do research. And I'm someone that absolutely loves to do research, and came, you know, have always been sort of more self-sufficient in doing my own biostatistics and needing to really be the boots on the ground to get projects done. It's been so amazing to me to see here. I've reached out to several mentors and have gotten projects started working on a couple of things. And what's so impressive when you talk about access at Stanford to research is just the access to those pieces that are going to really keep you up at night, like the IRB. And is there a research analyst that can clean your data and run it through Stata so that you don't have to do all of that work? You can just look at the output and be able to write it up. Like those are really the things that save you and are make it more make it easier for you to be able to be a more productive resident. And I think that that's something that's so unique here. There's always research mentors. There's, you know, a lot of places that I had interviewed at as an applicant would talk about, well, we have a research pathway. I'm like, well, what does that mean? Like, sure, this is great that I have this research mentor, but like, if I have to get an IRB done, if I have to, you know, like crank out my own statistics, like what are the resources that are in place to be able to help me do that? And I just want to convey to everybody that's listening that I think that that's been very unique here, and is why the residents are able to be so productive. And now I can really see that. So I think it makes it fun and great and takes that stress off of you.
And I would add that I totally agree with what Elena said. And if anything, it's almost too easy to find mentors. Like you have to be sort of choosy about what kind of projects you're looking for, what kind of subject matter, because this kind of gets back to what Dr. Rogers was saying about the lack of hierarchy, that people are so open to talking to and working with residents, and they are doing so much interesting work that you just have to make sure that you get some skills at choosing the projects that you can realistically accomplish, and not too many of them during your time as a resident. And just to speak to setting people up with research mentors, this is one of the topics that came up a lot in all of my one-on-one meetings with my assigned interns as a chief this year, that you know, we wanted to make sure that people who were interested in doing research had kind of a plan for who they would be approaching and who they were meeting with. And that seemed to be going really well for most people, about a third to a halfway during the year when I had most of these check-ins last. So that is one more mechanism we have to make that happen.
Yeah, and I would just highlight, I remember being so amazed at how approachable and willing to meet people were. I think by intern year, I emailed like 8 different people just asking to be willing to meet with me to kind of share the work they're doing, and if there's projects that I might be able to be a part of. And all of them were willing to sit down with me, made time for me. And that was just really amazing to me, coming in as like a bright-eyed intern, like not knowing anybody here, that it was so easy to just make those connections with people. And so, yeah, I think it's been a very easy process here.
And if I could just
please
just add one more thing that I found really, really cool. I started working on CCU first, and with every like rotation that I've done, specialty or otherwise, the attendings that you see working with you and the fellows that you see working with you, they are directly involved in research and they're directly involved clinically. And I think that makes such a difference in terms of, wow, I'm looking at this attending, he's teaching me this incredible stuff, and oh yeah, he's taking what he sees like clinically on the ground with me, seeing patients, and is translating it into bigger research questions. And I think that just makes it's so exciting. It's exciting to see that like melding of both the clinical side and the research kind of coming together at Stanford, which is really cool.
Thanks. Angela, as a physician scientist and somebody who, again, is very involved in the resident research, you want to maybe give your perspective?
Sure. I guess I would say I think Stanford does this well, and it's not easy, I think, to set it up, but now that it is set up, it goes well. The kind of research that you can do, essentially on your nights and weekends and with a month in your second and third year needs to be a specific kind of research. It shouldn't be that you're looking up some, phenotypes in EPIC and spending hundreds of hours trying to make a new data set. It really needs to be with a mentor who has data sets or clinical trials data or Stanford data, who, you're going to either do the bioinformatics or work with a statistician and do the writing and help design, like having something concrete. And that mentor has to understand that you might then go to the ICU and be on night float, and for 6 weeks they're not going to hear from you, and that's okay. And so because we do this well, we as your program directors know who are the mentors in GI or in oncology, in all the fields who are great at that. If you're totally undifferentiated, we have others, then it's like the world is your oyster, then let us give you 5 or 6 to start with, kind of like Adrian said, and just see who you connect with and ask some question while you're here. I think doing research during your residency not only prepares your fellowship or other letters well, but gives you a mentor relationship, a chance for continuity across the months where you're learning something, and a chance to get to go to a national meeting and hopefully write up your work. So it's an amazing thing, and we work really hard to have that be possible for all of our residents. So because it already works well, it makes it a lot easier to know, okay, this is what you're open to. Let me tell you the first 5 people to talk to.
Right. I see a question that actually was submitted by chat, so I can't click on it, but I'll read it because it's a great question. It says, and maybe Becca and Elena, maybe you could address. Can you speak to resident experiences engaging in health disparities work, advocacy, research, et cetera?
Sure, I can start out, and then Elena, feel free to jump in. So for these various aspects of advocacy research, I think more and more people are getting interested and involved in advocacy. So one of my co-chief, Amy, for example, not so much specifically about disparities, but it certainly relates. She is super involved in gun regulation advocacy and gun violence prevention. And there are an increasing number of residents who are advocating for all sorts of different vulnerable groups. So we have a very active LGBTQ interest group who's designing curricula around that. And then research-wise, I think for myself being interested in this, there's so many faculty members at Stanford who have a health disparities aspect to their work that it's really not difficult at all to find someone to work with who wants to take that angle. And then I would just say clinically also with the different sites, and I know we spoke to this in the beginning, but we do take care of a lot of different vulnerable populations. And then of course, with the ability to do clinical work or research overseas, that's yet one more way to get involved in health disparities clinically and research-wise.
I have nothing to add, honestly. That highlights everything that I was going to mention. I think there's a lot of opportunities to get involved. I think Rebecca hit them all really perfectly.
Thank you. All right. Is it feasible to not have a car? Are there discounts for public transportation? Indeed, but maybe I'll turn to the residents to answer that.
Well, Stanford will pay you $25 per month to not have a parking permit. I will point out you still have to come to work. You just don't drive your car. So personally, I ride my bike to work most of the time, and that is doable in a fairly wide radius around Stanford. I would say it is challenging to not own a car at all because of our rotations at Santa Clara Valley, which are wonderful, but that would be a very, very long bike ride because that's about a 30-minute drive from where I live in Menlo Park, just north of Stanford. So in my case, my significant other and I share a car, so I definitely don't need my own, but it would be a little difficult not to have one. That said, at least one of our third-year residents has gone through all of residency without a car, so it can be done.
Anything else to add, anyone? Okay. All right, maybe Errol, maybe you can speak as one of the academic hospitalists to this. Can you share about unique opportunities in med ed offered through the clinical teaching pod? And so if you could maybe talk a little bit about that. And I think one of the unique opportunities here clinically and in med ed is the Stanford 25, and you're so involved in that, maybe you can speak a little to that as well.
Yeah, sure. So as I think everybody who interviewed knows about the different pods that we have, Pathways Distinction. One of those pods, so there are in very many options from research to biodesign to education. And I'm in part of the education one. In fact, much of our med group, our Stanford 25 group, is part of that. It's led by Poonam Hosamani, who's one of the assistant program directors, and Dr. Abraham Verghese, who unfortunately couldn't join us today. He was supposed to be online, but he ended up having to travel to give a speech. So, but he is very involved with this pod as well. In fact, part of what we do is we go to one of our houses, or Abraham's house, and we host a dinner to start the year and stuff like that, as an opportunity just for you to get to know the faculty who are involved in education and passionate about education, so that we have that relationship. So throughout the years, we can help better understand what it is your goals are and help you make those goals. But aside from that, we also provide just tons of opportunities for you to do any sort of education experience that you want. One of the things I love about this program is you will come out of this program trained clinically really well to take care of a patient anywhere, and people will know that coming out of Stanford. But what this program does a great job of is create an opportunity for you to develop what it is that you will make you different than just a great clinician. You're going to be a wonderful clinician, but will you also be a great teacher, great researcher? What is that extra factor that's going to help you get into fellowship or get a job? And to do that, you need time and you need support. And the program does that amazing job of that. In fact, since I was a resident, they've only gotten better and better as far as allowing the opportunity to have the mentorship and the time to really accomplish that. So for those of you interested in education, we provide opportunities for you to educate, to teach students. You can do anything from leading a Stanford 25 session if you're interested, to doing Stanford 25 blog posts. But that's just one option. There's lots of teaching for medical students as well in so many different environments. And we really want to encourage you to think outside the box. Whatever it is that you're interested in, we can support you in it.
One nice opportunity is through the practice of medicine course that a number of our academic hospitalists are very involved in leading, which is for the preclinical medical students, where those members of that pod have the opportunity to do a lot of work with the medical students as well. All right. For residents not in the global health track, how much time is allowed for away rotations during residency? So this is, I think, one of the real highlights of our program is the Global Health Scholars Program, which allows residents to, usually in their third year, if they're not in the global health track, to spend 6 weeks overseas overseas, or we actually now have 2 domestic sites as well, in varied sites, both geographically, but also what you will be doing, from an urban inpatient hospital to a primary care clinic in Borneo, to a HIV TB co-infection clinic. It is universally, year after year, rated our absolutely #1 experience in all of residency. Becca, you were in the global health track, so you can probably speak better than anyone about the global health opportunities. Can you say a few words?
Sure. Well, I agree with everything you said about the Johnson & Johnson overseas and now domestic opportunities, which are phenomenal. And what I loved about those especially is that I was in Rwanda, so I can't speak directly to the others, but it was a very rigorous clinical experience, but also just a ton of fun. So I didn't feel like I was on some time-wasting vacation from residency. We have such limited time to train. You really want to make the most of it. I learned a ton there, and I also had an amazing time in general. In terms of other global health opportunities, so there is a global health underserved populations pod. I know someone asked a question about that. And that is a great way to, just like what Dr. Osalo was saying about the education pod, to meet your mentors early on. So meeting Sibel Renaud and Michelle Berry, who are the faculty most involved in that, right off the bat is super helpful. And then they bring in all sorts of other people who are in some way involved in global health in their careers for you to meet. And then in terms of other programming, there's a global health course, like more didactic, although very interactive as well, course that Sibel and one of the pediatrics faculty run, which is fantastic. There's global health journal clubs that are led mostly by the global health track residents. So, you know, it might be about kidney disease globally, or heart failure globally was one of the ones I led, that kind of thing. So there are so many opportunities that all add up to a really rich global health experience.
Great, thanks. I see we're running short on time, so maybe I will take this as the last question, and it's a nice one to end on. What's your favorite thing to do in Palo Alto? So maybe I'll just turn to everybody on the panel.
My favorite thing to do is the Alpine Inn, which is a beer garden, and as Amy always likes to share, the site of the first ever email transmission. That's off Alpine Road in Portola Valley, a beautiful green part of the world, a perfect thing to do before or after a hike.
Next. Errol.
I like the beer garden theme. There's a place right actually by Abraham's house called Free Wheel Brewery that has, when we were at a conference this year, cask beer. I never had it before, but in the UK the beer is like underground and shoots up. It's not no carbonation. It's amazing. So I'm going to just go with the beer theme and say going there and grabbing a beer afterwards.
Yeah, we don't want to give the wrong idea to applicants. Elena.
I think I'd have to say being able to bike here. I lived in a city for a while before, and I now get to bike to and from campus, which is fun. I live in Redwood City, so it's a little bit of a long distance. But I did discover that there's an Elena Avenue here in Palo Alto, so I'd have to say that's my favorite to bike down. I'm quite sure it was named for me, but yeah, biking in Palo Alto is probably my favorite thing to do.
Dr. Harrington.
Well, as all of you on the phone know, I live in Portola Valley, and I go to Alpine Inn a lot, so I'm going to look for Becca there now. But what I like is the fact that as a native Bostonian, I never have to wear anything heavier than I have on right now, which is the vest. And so come out here and enjoy some great outdoor living, and the hiking's amazing, the coast is amazing. Crossing the Golden Gate Bridge anytime in any weather is just an awe-inspiring experience. So the natural beauty here is unparalleled. So keep that in mind, because you got to do things other than work.
We haven't talked a lot about raising families here, but I actually feel like that's one of the amazing things is that on the weekends when you have time off, most people take time off and they spend time with their families in a way that's really great. And, you know, like in February, it's 66 and sunny today. You can take your children and go for hikes and go to the beach. And it's just fantastic. And it means that most people are in a good mood most of the year, which helps you when you're working hard. It's an amazing place to live.
Yeah. I couldn't agree more. I was trying to decide which of my outdoor things was the favorite. And I think going ocean kayaking out in Half Moon Bay, which, you know, is just like 35 minutes driving over here over the mountains, like that was by far one of my absolute highlights of living up here.
That's great. Yeah, I think when I was a resident, I would say the outdoors activities and the hiking, it's incredible these days. Actually, Angela and I both share this. I've got 3 daughters, she has 2, and I think all 5 of them are very involved in lots of sports. And so I feel like my weekends now are lots of basketball and soccer games, but they're actually a lot of fun. And because the weather's nice, you don't mind being out on the soccer field. And I had no idea that the club soccer scene was so serious in Northern California. Becca knows, she's nodding, having grown up here. But it really is an amazing place to live. Dr. Harrington didn't mention that he also grows wine, and in fact served some of his wine at this year's intern orientation. So we are hoping that he will again next year. So those of you who match here have something to look forward to.
Well, the 2017 harvest was a good one, and that's what we'll be getting ready to serve. So plenty of it. Yep.
All right. And, I say this not only because he's my boss, it was legitimately good wine. I would probably say that anyway, but it actually was really good. So yeah, something to look forward to. All right. I see we are 2 minutes over. I apologize. I want to be respectful of everybody's time. Sorry for those of you who didn't ask questions that we didn't get to. I'm sorry because we do want to be respectful of the time. But please do reach out, and if there's anything you want answered, please email me or any of us. It's been a lot of fun this whole interview season. Thanks for joining us today. Thank you for all of the panel for taking the time, and hope many of you spend the next few years with us, and certainly wish the best to everybody who visits Stanford this year.
Yeah, my email I think was on the invitation too, so feel free to email, and I can also triage questions and help Ron because I know he's gotten a lot. And also, this video will be online on our YouTube channel for the Department of Medicine. You're welcome to put comments there, and we can reach out and answer those comments so other people can see it as well.
Thanks, everyone.
Thanks, guys.
Thank
Thank you,
you.
everybody.